Yes, sir. Now we can go stream.
Okay, good evening, everyone. Good evening, respected faculties and all my dear colleagues. I am Dr. Pallavi from RN Tagore. I would like to present my case.
Okay, just wait. I just introduce to everyone to you, and then we'll start.
Yes, sir.
Okay. So good evening, everyone. We are in the back in Renal classroom. This is the 11th session, and for this we have, as usual, is a two parts. Part one is a case presentation, and second part will be the OSKI session. And OSKI session will be taken care of by Dr. Aniruddha Dattu, the junior consultant in a Kolkata Kidney Institute. And for the case presentation, we are delighted to have Professor N. Gopal Krishnan. He needs basically no introduction. He has a huge academic and administrative career, and former director of the Institute of Nephrology of Madras Medical College, and presently the member secretary of the Transplant Authority of Tamil Nadu. He is the chairman of the Scientific Committee of Indian Society of Nephrology and had the joint chairing committee of the World Kidney Day as well as the WCN. He was the scientific committee co-chair, and he was a former institute and body and selection committee members in the AIMS New Delhi. And he has a huge publications, more than 195 publications with a high index journal publication 31, 17 awards and orations, 18 chapters in a book, textbook, and he received the Good Governance Award from the Tamil Nadu government of Tamil Nadu. And he was the nodal officer of the COVID care. He's an innumerable students and trained almost around 100 nephrologists. And he established the fast maintenance hemodialysis in the government sector and started dialysis services in this Chengalpattu Medical College in 2007. And he served as an ICMR CKD core committee member, served an ISN INO CKD member, principal investigator of Tamil Nadu prevalence of STEP survey, and he has been part of the credence testing trials and ICKD cohort study. Apart from his huge academic and administrative career, he is respected all over the country as a teacher and mentor because of his, apart from this, is a basic and very good humanitarian character. And we are delighted to have you, sir, in this meeting. And there, Pallavi will present the case. And Pallavi is the third-year resident in RN Tagore Hospital, exam-going DNB student. She will be presenting the case. So, Pallavi, you can take the permission from your teacher, and you can start the presentation.
So, shall I start?
Yeah, thank you, Dr. Pradas, for those kind words. Am I audible? Clarity in my voice?
Yes, sir.
Yes, sir.
Yeah, fine. Thank you so much. It's my pleasure and privilege to be part of this academic exercise. Thanks, Microlabs, for arranging this academic initiative. The case presentation and discussion is always a pleasure, and it is a joy. So, the clinical medicine is a vast ocean. It is full of clinical medicine is highly innovative with the explosion of current knowledge. See, now we are in a stage, vantage position to kind of understand and witness the transformation of the disease profile and the trend changes in the disease profile and the concept changes pertaining to every disease, and with advancement of newer therapeutic modalities and so on. So let us utilize this next 1 hour or so.
Yes.
Encourage Dr. Pallavi to be at ease. My sincere advice would be just relax. You feel as if you are just presenting a clinical case that is assigned to you in your ward round. And you just be at ease, then the best out of you will come out.
Okay, thank you.
And also, I'll tell you that, nobody can know the answers of all the questions, answers for all the questions. It's more of a kind of a discussion. And how I'll take the discussion is that, and predominantly it be pertaining to the clinical case scenario that you are going to describe, and little bit of theoretical considerations wherever it is required. So that will be the style of my discussion. Please go ahead and enjoy the session.
Okay, thank you, sir. Shall I start? So,
Yeah, please.
my patient, Mr. X, 48-year-old male, resident of Myanmar, businessman by occupation, graduate, informant, self and history reliable. Patient is currently diabetic for 5 years, hypertensive recently diagnosed, and chronic kidney disease on maintenance hemodialysis for last 3 months with maintenance hemodialysis 3 per week. Present access was right internal jugular tunnel cuff catheter. Patient presented in the OPD with the complaints of low backache for 4 months, generalized weakness for 4 months, and swelling swelling of entire body. The patient was apparently asymptomatic 5 months back in June 2024 when he developed high-grade fever and pain abdomen, and for which he was admitted in local hospital in Myanmar, and he was diagnosed to have liver abscess, bloodstream infection along with renal dysfunction of creatinine 8.6 and low hemoglobin of 8.2. So, in view of decreased urine output and shortness of breath, hemodialysis was initiated to right internal jugular venous double lumen catheter, and 1 unit blood transfusion was given. Subsequently, liver abscess resolved with 6 weeks of IV antibiotic, but dialysis was continued as complete renal function was not restored and urine output was persistently less than 400 ml per day. So, right IJV tunneled cuff catheter was inserted and maintenance hemodialysis was continued. Patient was diabetic. Patient was detected to be diabetic for 5 years back during an episode of UTI. Initially, he was started on oral hypoglycemic drugs. Then later, he was shifted to injection insulin in view of poor glycemic control 3 years back. Patient had a history of passing large volume of urine, more than 3 liters per day during daytime with frequent urination during nighttime. And patient is hypertensive for 5 years with well controlled on 2 medications. Till this point of time, during at the time of June 2024, when the patient was started on hemodialysis, he never had any complaints of prodyurin, hematuria, loss of appetite, pruritus, visual disturbance, or any tingling numbness in any limbs. So he came to the OPD in November 2024. That time he had complaint of low backache for 3 to 4 months, dull aching, non-radiating, increasing with movements, and mildly relieved with rest and oral analgesics. Pain was not associated with shooting pain or stiffness in leg. There is history of large joint pain also, bilateral knee joint, wrist and shoulder, but it was not associated with any redness, swelling or morning stiffness. Patient had history of generalized weakness and easy fatigability for 3 months, and it was started while climbing 3 flights of stairs, and it was progressive, increasing on walking and performing day-to-day activity. Patient also had a history of 3 units of blood transfusion over the last 3 months. Even in till November 2024, even in this 4-5 months, he did not have any history of any jaundice, hematuria, any weight loss, night sweats, any history of recent trauma, joint swelling also. It was not at all associated with chest pain, sweating, cough, orthopnea, and there was no history of any visual disturbance, tingling, numbness in any leg, any limb. Plus, he did not have any history of any high-risk behavior. Coming to the personal history, patient is non-vegetarian. He had intermittent constipation, passing hard stool every 2 to 3 days with straining over the last 1 month, normal sleep cycle. He is chronic smoker and denies alcohol addiction. In the family history, his mother was diabetic. Age of onset was 60 years and well controlled on oral hypoglycemic drugs. Otherwise, there was no history of any significant renal disease in parents, siblings, and no history of any malignancy. Patient did not give any history of ischemic heart disease, severe or major surgery in the past. Sir, should I summarize?
Yeah, please summarize. Please
Yeah.
summarize.
Sir, a 48-year-old diabetic and hypertensive gentleman with chronic kidney disease diagnosed 5 months back when he presented with liver abscess and renal dysfunction, now requiring maintenance hemodialysis with history of backache and large joint pain for 4 months, associated with generalized weakness and fatigability for last 4 months. He had significant history of NSAID intake for pain, had received multiple blood transfusions for anemia, and now admitted for further evaluation and management. So, summarizing my case summary, till now, my probable diagnosis is chronic kidney disease on the maintenance hemodialysis. Probable etiology may be diabetic kidney disease with CKD mineral bone disorder, or patient can have multiple myeloma with diabetic kidney disease. And my third probable diagnosis will be accelerated worsening of pre-existing kidney disease due to infection or NSAID intake.
Well, actually, can you just explain to me the difference between the first possibility and third possibility?
Diabetic, sir, I am considering diabetic kidney disease because patient was diabetic for 5 years, not on
I
well,
know. Yeah.
not well controlled. He was having renal dysfunction, although sir, it was very heterogeneous presentation, not the typical presentation
So
of.
you mean that accelerated worsening of pre-existing diabetic kidney disease, right?
Yes, sir.
Yeah, that's what I didn't understand because you didn't put it as diabetic kidney disease. Pre-existing kidney disease, meaning something else you are thinking in terms of a thought.
No,
So
sir.
you mean to say underlying diabetic kidney disease worsened by infection and NSAIDs, right? Am I right?
Yes, sir.
Okay, fine. And what made you think in terms of multiple myeloma?
Sir, I am keeping multiple myeloma because considering, sir, severe anemia of the patient, bone pain, and renal dysfunction, severe renal dysfunction, and present and patients are by clinical history, patient did not give any microvascular or macrovascular complication of diabetic. So I am keeping non-diabetic kidney disease as a probability, probably myeloma.
Okay, fine. So coming back to history, there are some more things I would like to know. What is his profession?
Sir, he was businessman by profession.
That you should mention, and about his family,
Sir,
about children.
Sir, there is no history of any renal disease in the children. Only
No, you said about the siblings only. You mentioned siblings.
Oh,
Even
sir, only
yeah,
her mother was his mother was diabetic.
that's fine. You mentioned about the parent. You mentioned about the siblings. I mean, you didn't mention whether he's married or. I mean, even though it may not have a gross significance with the current situation, let it be complete. You know, he's married, having children, and he's a businessman, and whether his profession has been interrupted because of this illness, and how is his functional ability. Better if you add all those things also, it'd be fine.
Okay.
Okay, fine. You said he's from Myanmar, right? He lives in Myanmar, has come down to India for treatment, or he
Yes,
has
sir. He
settled
had
down in
come.
India?
No, no, sir. He had come down for treatment and he's still
Oh,
in.
fine. That's good. Okay. You said he's a diabetic for about 5 years and not under good control at all. And the evidence is that he has been producing a lot of urine,
Yes, sir.
right?
Yes,
A
sir.
large volume urine, probably because of uncontrolled hyperglycemia or anything else you think in terms of.
Sir, polyuria can be due to it can be due to glycosuria can be one thing, and second, sir, it can be due to tubular dysfunction also. And if we consider myeloma, then even sir, hypercalcemia can also can also present like polyuria.
No, because why I'm asking this question is that your first possibility is diabetic kidney disease.
Yes, sir.
How often you come across polyuria in diabetic kidney disease? Because of diabetic kidney disease, the classical presentation is glomerular pathology, you know?
Yes, sir.
Yeah, edema, proteinuria, worsening hypertension, right?
Yes, sir.
Most often they become oliguric rather than polyuric.
Yes.
Why this history? I appreciate that you have elicited this history. what do I surmise is that straight away we cannot set aside saying that at presentation itself he had CKD. There is no evidence for that.
Yes.
Maybe, but anybody's guess. But there is no clue for presence of CKD at presentation because he has been polyuric. You said you made a important negative history of no frothy urine, right?
Yes, sir.
And so even if the tubular component was more in a diabetic pathology, it should be more of nocturia rather than more volume of urine during the daytime. Got my point?
Yes, sir.
Yeah, because specifically you mentioned the more quantity of urine in the morning time rather than the night time. Normally in CKD with the predominant tubular pathology, it will be the other way around, right? It's more
Yes.
of nocturia.
Nocturia more than polyuria, sir.
So more than 50% of the urine volume, 24 urine volume, if it is passed in the night, you call it as nocturia. And some people used to say that, it is the only specific symptom for kidney failure. All that is gone, it's all more relative, and nowadays we don't attach too much of significance for this particular point, but it is a classical traditional teaching of yesteryears. The nocturia is the only specific symptom for kidney failure. No other symptom is purely specific for kidney disease, right? That's it. But here it is the other way around. It is ulta. So no edema, no history suggestive of proteinuria. He has been otherwise fine. So it all started with a kind of a liver abscess and subsequent problems. So as such, there is no evidence to say that he had already pre-existing CKD as such. He might have had, but from the historical perspective, it is not so. Do you agree with me or not?
Yes, sir.
Fine. You said he was down with the liver abscess. Liver abscess is not a very commonly encountered sepsis complication. Can you just elaborate liver abscess in the context of this particular person as to why it happened and what is your thought process?
Actually, the patients have developed liver abscess followed by bloodstream infection, might be secondary to poor glycemic control. But sir, could not get into the more cause because we didn't get, sir. Actually, this was all told by the patient, so we didn't have, sir,
Fine.
any.
Okay. So
documents
what I
available.
surmise, yeah, I understand. It's probably you could not go through the elaborate records of that initial treatment. So the liver abscess subsiding without any aspiration and all that. What is the differential diagnosis? How is it caused? What is the etiology for that? I understand. I agree with you. Diabetes, vulnerability for infection, and probably septicemia and seedling of the septic foci in the liver resulting that. Is it simply that or something else you have to think in terms of patient is hailing from Far East country?
Sir, we have to keep in mind, sir, bacterial plus hydrated, sir, this all thing we have to keep in mind.
Hydrated is not abscess, liver, it's not
Bacterial is the
abscess.
most common.
Yeah. So amoebic liver abscess is more common in alcoholics.
Alcoholics
He's not
and
an
diabetic.
alcoholic, right? He's
Yes,
not an
sir.
alcohol consumer. Yeah. So amoebic liver abscess is one, and then pyogenic liver abscess.
Pyogenic liver abscess.
So normally, pyogenic liver abscess is not a very common occurrence, even though diabetics are highly vulnerable to develop that. Usually is a complication of right-sided lobar pneumonia due to Klebsiella or a septicemia of other causes, or as a complication of endocarditis, you can get that. And have you heard of myelioidosis? Yeah, any visceral abscess, when the liver abscess is there, if it is not amoebic liver abscess, if there is no other predisposing infectious entity that could culminate in liver abscess like pneumonia, and there is no infective endocarditis, and one has to rule out myelioidosis, particularly patients hailing from Thailand and the Far Eastern countries and so on.
Okay.
Visceral abscess. Okay, that's it. Fine. I agree that any major infectious illness can tip the balance of kidney functional status in a diabetic. I agree with that. Okay. So what is the natural history of sepsis associated acute kidney injury?
Sepsis, sir, 20, sir, almost one fourth of sepsis, sir, might not resolve and, sir, may lead to, sir, chronic tubulointerstitial damage, leading to SRD. Rest, sir, 50 to 60% might resolve with a good renal recovery.
You are right. Actually, sepsis is variable course.
Yes, sir.
What starts as AKI can go in for AKD, right?
Yes, sir.
AKD. And then AKD can go into CKD.
Really.
Some of them completely resolve, and some of them the most vulnerable. If they say, we have come across instances of severe septicemia and septic shock, even resulting in cortical necrosis. Okay, so sepsis and that too, the modern day bugs, multi-drug resistant bugs, they are really, really injurious. Okay, how does sepsis affect kidney?
So, sepsis cancer, first, it can cause a pre-renal glomerular injury, first pre-renal. So, second, it can cause intrinsic renal injury in the form of tubulointerstitial damage or acute tubular necrosis. Followed by if the sir, inflammation is prolonged, then they can further proceed to AKD and CKD, sir.
Fine. Yeah, one is hemodynamic disturbances. It can septic shock can result in that. That's number one. And then the cytokines, which are elaborated.
Yes, sir.
They also can have impact on the kidney function, independent of the hemodynamic perturbations. And number three, the drugs that are used for this thing. These are the common things. And sepsis-associated acute kidney injuries become a real problem nowadays, and that can just progress to AKD and then CKD in some of them as well. I appreciate that point. And so what else you said, any drug that is given for diabetes can increase in the urine output?
So, diuretics.
No, for diabetes, we don't give diuretics, right?
For
Anti-diabetic.
anti-diabetic, that can
Because if this patient has been producing a lot of urine, we don't know what drugs he was on. Any drug which can increase the urine output in some patients at least.
sir, SGLT2 inhibitors.
Yeah, you're right. It's a bit surprising that not all the patients on SGLT inhibitors, they pour a lot of urine. But it is an important point, like some people definitely, they complain of that, increase in the urine output. And this point is very important because, if a particular patient is on diuretic as well for presence of edema some time ago, and if you start SGLT inhibitor, specifically you have to warn them that if there is disappearance of edema and more urine output, there should be moderation of the diuretic doses as well. Okay, that's fine. So that was the tip off from which the kidney disease started in him. We really don't know whether there was underlying CKD due to diabetes, or it all started as AKI and that has gone in for AKD and CKD.
Yes.
That's it. Then on top of it, after dialysis also, he didn't do well, right? He became really fatigued and anemia. And we are not aware as to how this anemia was approached. 23 units of transfusion, that's what you said. Whether workup for iron deficiency and iron was given or erythropoietin was given, all those details probably you're also not aware. So inexplicable anemia in a patient who's on dialysis, okay, like in this patient, what will be an algorithmic approach? Disproportionate anemia, warranting transfusion.
Sir, disproportionate anemia. Sir, first I would like to look for any active blood loss is there or not.
Very good.
Sir,
Very good.
second is any occult blood losses has to be looked after because the patient was already taking stool NSAID for a long time. So I would like for occult blood loss can be there. Sir, patient on dialysis, due to the, sir, even in dialysis, the patient can have blood loss in the form of extracorporeal blood loss can be there, although it is very low. And sir, fourth is due to the patient being long-term diabetic, CKD, on maintenance dialysis, because of the inflammations are also there can be some functional deficiency of the iron can be there. And patient, sir, can also, being a long-term diabetic, sir, patient can also have erythropoietin deficiency that can lead to iron. And sir, last cause, nutrition deficiencies has to be taken care of.
Yeah, fine. I mean, iron deficiency, folic acid deficiency, vitamin B12 deficiency,
If the patient is even on
and
8
blood
inhibitors
loss
or
in
ARBs,
any
they can
form.
also lead to anemia.
Yeah, blood loss and all that I mentioned. In addition to that, a severe hyperparathyroidism. Not in this patient, because it was only patient has been on dialysis only for 4-5 months and so on, but still we don't know. Severe hyperparathyroidism can result in erythropoietin refractory therapy, because there is a marrow fibrosis, right?
Yes.
And you nicely mentioned about the functional iron deficiency because of hepcidin that will not allow the iron to be mobilized to the bone marrow, and that also can be contributing. And last but not the least, underlying chronic inflammatory conditions, particularly tuberculosis, number one, and then malignancies. Okay. So systematically, we have to rule out all these deficiencies, blood loss. Okay, do a peripheral smear, look at the morphology of RBCs, and do iron studies, particularly ferritin, always in combination with percentage transferrin saturation, because ferritin as a single investigation does not take you anywhere. High ferritin can be due to inflammation itself. Yeah, there can be high ferritin, even iron deficiency. So looking for evidence of blood loss, like stool fecal blood and other things and so on, and have a low threshold for upper GI endoscopy. After finishing all these things, look for severe hyperparathyroidism, and then rule out chronic infections like tuberculosis, and then finally malignancy. So this is one of the factors why I'm elaborating on this, is that because you said this anemia prompted you to think in terms of myeloma, right?
Yes, sir.
We can think in terms of myeloma only when and only if you have ruled out all these things.
Yes, sir.
Okay, that's fine.
Anemia is the main cause.
And another point is that a severe bone pain, is it not? Yeah.
Yes, sir.
So what are the causes for bone pain in a patient on dialysis?
Sir, patient who are having CKD, MBD with high turnover bone disease, actually they present with bone pain. But those patients who are having osteoporosis, adynamic bone disease, they are usually painless unless they are having any microfractures or any vertebral collapse. At that time only they can present with bony pain.
But according to some authors, low turnover bone disease, particularly adynamic bone disease, also can present with severe bone pain.
Yes, sir. So my
opinion differs.
differential for the bony lesions on patients on CKD on dialysis would be ostitis fibrosa. It can be due to the brown tumors also. There can be calciphylaxis.
Yeah, fine.
This thing, sir, and osteomalacia.
Fine. And one thing I didn't know why this gentleman had the arthralgia. It was for arthritis or near presentation, large joint and small joint and all that. Was it arthritis or only arthralgia?
Sir, arthritis can be mostly due to degenerative process, but arthralgia is due to systemic. It is the inflammatory process are mostly leading to arthralgias. They will maybe accompanied with high ESR, CRP, and with morning stiffness.
Okay, fine. And then we see NSAIDs like diclofenac, right?
Yes, sir.
Okay. So you have mentioned that that also could have contributed to failure. Yeah. How does it cause kidney failure?
Sir, pardon, sir, I didn't hear you.
How does how does it cause kidney failure?
Sir, your voice is not clear.
I'm audible now. Am I audible?
Yes, sir.
Yeah. I was just asking as to how NSAIDs cause kidney failure.
Sir, NSAIDs, they usually cause afferent arteriolar vasoconstriction, decreasing the renal. They basically reduce the renal perfusion by constriction of the afferent arteriole, and after that this is one mechanism, hemodynamic, or second they can cause acute tubulointerstitial damage also. So in the long run, it can cause acute tubulointerstitial damage, CTIN, and ESRD, sir.
Right. Yeah, can cause multiple mechanisms. So hemodynamically mediated acute injury is reversible. Whereas this AIN, acute interstitial nephritis, sometimes may not be reversible. It can prolong. It can progress to sick. So I appreciate that you have taken this point. Then what happened to him? Oh, yeah. So, yeah. Can you just quickly finish the clinical examinations and we'll continue further?
Yes, sir. In the general examination, patient was conscious, alert, oriented to time, place, and person. Pallor, edema was present. Although icterus cyanosis clubbing lymphadenopathy was absent. In vital signs, pulse 76 beats per minute, regular with no radioradial or radiofemoral delay. Blood pressure was 120 by 80 millimeters of mercury. Taken on right arm in supine position. Respiratory rate was 16 breaths per minute. In the cardiovascular system, S1, S2 was heard normally. Apex beta was localized in the fifth intercostal space. Only there was ejection systolic murmur at the pulmonary area. In the respiratory system, it was no significant abnormality was found. Gastrointestinal system also, abdominal was soft, non-tender, no organomegaly. In the CNS, cranial nerve was intact. Motor system, reflexes, and sensory system. All the systems were intact on the general examination. Coming to the muscular system, skeletal system, patient was having midline tenderness over vertebral spinous process. There was no rise in temperature, erythema, or swelling in the lower back, although patient was having reduced spinal mobility during flexion, extension, and rotation. And in the fundus examination, there was no evidence of any retinopathy.
Oh, fine. So the positive findings are severe bone pain, right?
Sir, the positive finding
Bone
was
tenderness, right?
yes, sir. Midline tenderness
Bone
was
tenderness and restriction of movement because of pain, or probably restriction of movement was because of pain, right?
yes, sir.
Yeah, am I not audible? Am I not audible?
No, no, sir. Audible.
Fine. Okay, fine. That's it. So no evidence of retinopathy. So diabetic retinopathy.
Pardon, sir.
You said no evidence of retinopathy. Probably you meant diabetic retinopathy, right?
Yes, sir. Diabetic retinopathy.
What is the inference? Diabetic retinopathy.
Sir, diabetic retinopathy, sir, basically we need to look for whether patients are having NPDR or proliferative diabetic retinopathy or not, because, sir, mainly the proliferative diabetic retinopathy is more associated with the microvascular damage and is correlated with diabetic nephropathy.
Yeah. So even though it is not 100% concordance, at least
Yes, sir.
40 to 60% concordance is expected, between retinopathy and nephropathy in diabetes.
Yes, sir.
So
Type 1
absence of retinopathy is also, absence of retinopathy is one of the factors that you have to prompt. It has to prompt us to think in terms of a non-diabetic kidney pathology, right?
Yes, sir.
Hello. People know. Hello.
Hello, sir.
Yeah. So absence of retinopathy again is a pointer to think in terms of a non-diabetic kidney pathology, right?
Yes, sir.
Yeah. Fine. So that is important. Absence of retinopathy is important. Okay. Does the any features neuropathy, peripheral neuropathy?
Sir, your voice is breaking. Could not hear.
Oh. So I'll just get disconnected and then get reconnected again. Okay.
Sure, sir.
Somebody from our desk should contact with the Professor Gopal Krishnan.
I am not there today.
Yes, sir. We are calling sir now.
Yes, yes. So once you finish the examination, you can stop this screen sharing.
Yes, sir.
And investigation, if they are asked, then only show the investigations. Sir was asking about this neuropathy and nephropathy association. So like that, how much is the concordance and discordance in neuropathy, and it is a later phenomena than nephropathy, or is an earlier? Okay, he has joined, yes.
Am I audible now?
Yes, sir.
Yes, sir, yes.
Yeah, fine. Right. So I was just asking, is there any for peripheral neuropathy or autonomic neuropathy?
Sir, by history, we could not get any symptoms of any autonomic or peripheral neuropathy.
No, the clinical examination.
No, sir. Actually, sensory system and reflexes all were normal, and even
Yeah, that you have.
yes,
Right?
sir. And even in
I
CT,
think
sir, there
it's
was
diabetic.
no evidence of any gastroparesis or sir, any system autonomic neuropathy in the form of orthostatic hypotension or erectile dysfunction.
Okay. And there's no postural hypotension.
No, sir.
Okay. So these things quickly get made, make up, or at least keep in mind. And if if it is asked, definitely you should be able to say that. Okay, fine.
Yes, sir.
So any diabetic are looking for evidence for all the micro and macrovascular complications. That's very important. Palpating all the peripheral pulses, history of asking for claudication pain to rule out the vasculopathy of the lower limbs. Yeah. Other stuff, autonomic neuropathy like erectile dysfunction and gustatory sweating. These things also you should and you have to make a mention. Okay, fine. So how was the patient investigated?
Sir, we investigated this patient as, sir, the baseline investigation in the CBC, the patient was having severe anemia, hemoglobin 5.6, rest TC and platelet were normal. Calcium was on the higher side. When we adjusted to the albumin 2.37, the corrected calcium was 11.76. The patient was having a phosphate of 5.6, uric acid 6.2, creatinine of 6.5, although patient was on hemodialysis. PTH was 14.2, sodium 133, sodium potassium bicarbonate is a normal, and LFTs are also on the normal side. Coming to the albumin, it was 2.37, and there is AG ratio reversal is same, 0.5. On imaging, USG KUB, kidney sizes was normal, but CMD was altered and increased echogenicity was found. And in the urine analysis, there was 2 plus protein with 5 to 10 pus cells, 0 to 2 RBCs, and glucose was 1 plus, and there was no evidence of any cast or crystal in the urine. The serology was negative, C3, C4 negative, and ANCA profile was also negative. In the 2D echo, sir, there was mild LV systolic dysfunction, otherwise ejection fraction was normal. And
That's
CT,
fine. Okay.
yes, sir. And CT whole
Yeah.
abdomen was done, showing hepatosplenomegaly with extensive small lytic lesions of the visualized bones, and there was also features of volume overload in the form of ascites, pleural effusion, and pericardial effusion. Then after this CT whole abdomen, we did a skeletal survey. So there we had seen punched out lytic lesions throughout the visualized AP and lateral aspect of the appendicular skeleton, mostly in the sternum or sacrum area.
Okay.
Sir, on the till now, sir, since we had till investigation, we had severe anemia, hypercalcemia, and AG ratio reversal was there with the punched out lytic lesions. We screened the patient for myeloma profile. In this protein electrophoresis, there was significant M band was detected in beta 2 region, and we further proceed for the serum immunofixation where it was positive for kappa band, and in the serum free light chain assay was done where there was kappa free light chain was 16,000, lambda was normal 16, and ratio was sir in 1019 for this patient. With positive M band, positive serum immunofixation for kappa band, and high serum FLC ratio, so we proceed for bone marrow biopsy. And in the bone marrow biopsy, the plasma cell infiltration was seen to be 70%, and there was hypercellular marrow was seen. Sir, should I proceed?
No, actually, there is one doubt. Actually, go through the serum protein electrophoresis slide. Yeah. So where is the M band?
Sir, M band, sir, detected in beta 2 region.
What's your impression? So normally we expect, where do you expect the M band here in the serum protein electrophoresis in myeloma? It has to be gamma globulin, right?
Yes, sir.
Yeah. So it's not in the beta or alpha and all that, Normally we expect a M band in the
Gamma globulin.
In fact, serum protein electrophoresis has not picked up anything here. It has just shown the beta 2 globulin is high. Naturally, beta 2 globulin is high because of the increased free light chain. So it is not M band. M spike actually should demonstrate in gamma.
Gamma globulin.
Okay, but of course it is demonstrated hypoalbuminemia. So serum protein electrophoresis not really detected. It is not really diagnosed. That is why fixation has been done. Because now serum protein electrophoresis has got its own limitations. It is a preliminary test, right? It's only a preliminary test. It is not very sensitive. Fixation is more specific and more sensitive. Okay, so in immune fixation, how is it being done is that the fraction of importance is found out by applying antibody to that fraction. Am I audible?
Yes, sir.
Yeah. So it picks up, it really sells as to which component is actually increased and so on. So this increase in the beta band, in beta region, is of not much relevance here. It is not confirmatory. Probably the beta 2 microglobulin is increased, and so probably it is reflecting that. On the absolutely confirmatory of myeloma. So there is no diagnosis. Of course, immune studies have shown lot of likely out lesions and so on. So the diagnosis is very clear now. That is myeloma. Okay, fine. So how will you proceed now?
Sir, after M band was there, so sir, ideally we need to proceed for the serum fixation and serum free light chain assay has to be done because sir, serum protein electrophoresis has
Yeah.
got only 80% sensitivity. The sensitivity increases more when we combine all the three tests together. So sir, after confirmation of the diagnosis, I would sir like to first go to the bone marrow. If the bone marrow, in bone marrow, if there is fulfillment of the criteria for multiple myeloma, then we can directly start treating the patient. But if the patient is having less than the cutoff range, if they are falling in the range, they can have sir other diseases like a smoldering myeloma, or we need to rule out sir smoldering myeloma, MGRS, MGUS also. So once after ruling out all this, and if the patient is fulfilling the criteria for multiple myeloma, we need to start treatment with the chemotherapy regime.
I understand, but let us talk about this point only. Now, it is not smoldering myeloma, it is not MGR. It's a clear-cut demonstration of M band is there in the immune fixation. Immune fixation, actually, if you go through that, it has shown the kappa light chain as well as IgG heavy chain. Both are significantly elevated. So it is a classical multiple myeloma. It is not smoldering. Now, my question is that how will you proceed now? How will you proceed now in this particular patient?
Sir, in this particular patient, sir, first we did the bone marrow. The bone marrow was showing 70% plasma cells infiltration was there. So, sir, we did the sir, after doing the bone marrow, we send the bone marrow sample for one sample for fish also for to get the cytogenetics. And then, sir, we started the patient first. We taken care of the symptomatic treatment, and then directly we started with the chemotherapy. We given the sir with the cybod regime. Sir, generally we have given to this patient.
So, so did you think in terms of performing a kidney biopsy in here?
No, sir, the criteria for multiple myeloma is fulfilled on the bone marrow. So, sir, I don't think that there is need to
So
do.
what is the likely pathology? What is the likely pathology in the kidney in this gentleman?
Sir, the likely pathology in multiple myeloma can be, sir, cast nephropathy can be the one possibility.
No, in this patient, what do you think is in this patient?
In this patient, sir, considering multiple myeloma, if the renal parts are cast nephropathy can be, sir, my first presentation, my first diagnosis will be.
Nephropathy, right?
Yes, sir.
So, so what is the clue? Actually, based on the free light chain assay, can you suspect the cause nephropathy, light nephropathy? According to others, if the light chain assay is beyond point, if you rule out infections, dehydration, NSAID associated kidney disease, and hypercalcemia associated kidney disease, if beyond a particular point, actually even without kidney biopsy, you can surmise that it is carcinopathy. Okay.
Yes, sir.
So the marker says even 150 milligram per deciliter. If it is beyond that, that itself enough. Of course, before, whenever there is a kidney dysfunction in a patient with myeloma, you have to think in terms of a hypovolemia, because hypovolemia is very common in them. Now you realize why he was passing large quantities of urine.
Excuse me, sir.
Why he was passing large quantities of urine.
Sir, he was passing lots of urine, sir, probably due to, sir, hypercalcemia induced tubular dysfunction can be, sir.
Hello.
Okay.
So probably because of hypercalcemia.
Yes, sir.
Me? Yeah. Probably hypercalcemia was the reason for this large volume of urine. Because chronic hypercalcemia will lead to polyuria. You know that?
Yes, sir.
Yeah. So probably hypercalcemia could have been there for some time. Okay. So that can cause polyuria. There are multiple mechanisms. Please go and learn as to why hypercalcemia causes polyuria. So that is a factor in him. Fine. So if you rule out hypercalcemia, infection, and NSAID and other things, if they prove that so that's what others say. And many times patients and they may have thrombocytopenia and all that, performing biopsy may be difficult too. So it's not always required to do biopsy to prove that it is carcinopathy. Okay. So
Yes,
if you do a kidney biopsy, how does it look like? Can you just describe the carcinopathy in the kidney biopsy?
sir, in the cast nephropathy is HNE in HNE on HNE stain. It looked like a, sir, fractured cast because of the laminated structure is there with angulations, and there is surrounded by the giant cell inflammation is there.
প্রোগ্রামটা তো ফ্লপ হচ্ছে তোমার।
Bye.
কেউ একটু ফোন করে বলেন স্যার আপনাদের শোনা যাচ্ছে না, একটু জোরে ফোন করে।
Hello, sir.
So, sir was asking, what will you see if you do a kidney biopsy in a patient? When will you do kidney biopsy and what will you see in the biopsy?
Sir, indication of kidney biopsy in myeloma patient is sir, when the patient's diagnosis is not clear, nephrotic range proteinuria is there. If it is associated with any hematuria or any external involvement is there, In the kidney biopsy, the classical finding is cast nephropathy, and in cast nephropathy, sir, we get on HNE stain, we get the laminated appearance with the laminated. It is a pink, bright eosinophilic cast with the laminated appearance with angulations, and so it is associated with the giant cell inflammation around.
Which part of the tubule you get this cast and what is classically called?
So we generally get this in the DCT, distal collective.
Yes. Why do you get in the distal tubule?
So we get distal tubules because of low pH, low sodium, and sluggish flow in the DCT that favors the formation of cast when a light chain is combined with TAM phosphol protein and forms the cast
Has
nephropathy.
joined. So we are in the time of the indication of kidney biopsy, and when you do, how will you look in the kidney biopsy? How does it look in the biopsy? Sir was asking that. Hello.
Hello.
Hmm? Hello. Okay. Probably the may miss the link. So what is this classically called? This is this cast.
So fractured cast.
Okay, fractured cast. And why is it distal tubule? Because the TAM phosphor protein is secreted in the thal. That's why.
It is a TAM horse protein is secreted in the thick ascending limb, but because of the low pH in the distal tubule, it favors the formation of cast over there.
Okay. So is it the cause that is causing the renal failure, or it also induces something else in the biopsy in the
So
tubule?
it induces the inflammatory reaction. Because of it, there is renal failure. Cast itself do not cause renal failure per se.
You will get also interstitial. What is a myeloma kidney in the biopsy?
Uh, so myeloma kidneys are one is cast nephropathy can be there. Second,
If the inflammation is very severe, it invites.
cytokines are
Giant cell type of,
giant cell
you can get a
inflammation can be.
granuloma.
Yeah, yes, sir.
If you get a granuloma along with that, then you call it a myeloma kidney. Okay. And what else you can see in the biopsy if you do a biopsy in a patients of multiple myeloma? What else you can see?
Sir, other find sir, mesangial deposits we can see.
What other pathologies? One you should told that is a cast nephropathy, and you'll get a fracture cast and tubular intestinal inflammation, maybe a granuloma formation. What else?
Sir, other paraprotein dependent renal lesions can be due to sir amyloidosis and uh,
You can get other pathology like amyloidosis.
amyloidosis and light chain deposition disease can be there. So, in amyloidosis, sir, there can be mesangial deposits in the plus they can have a deposits. Amorphous deposits can be found in the glomerulus plus in the vessels on the in the capillaries and in LCDD in sir MIDD deposition disease, the depositions can be found in the GBM TBM. Plus, sir, they have a striking feature that they have a nodular glomerulosclerosis like feature on the mesangium.
So how does this, if you get an amyloidosis, how it is stained? What about the past stain and the H&E stain about in amyloidosis, and what is the special stain? The side is back here. Yes. So you can ask questions. So you are not audible actually.
Sir, we could not able to hear you.
Hello.
Sir. Sir, I think you are muted. Gopal Krishna, sir, you are muted, I think. No, sir. We could not hear you.
So you are allow him to join.
Sir is already there.
Sir is there, but we cannot hear him.
Gopal Krishna, sir, can you hear us?
He needs to unmute himself. Sir, please
Yes.
unmute yourself. So we cannot hear.
Sir, can you hear us? Gopal Krishna, sir, can you hear us? Ah.
So he can hear us, but we cannot hear him. So is there anything to be done?
Sir, we request you to kindly log out and rejoin once again. That may help us.
Yes. Log out and join again.
Gopal Krishna, sir, can you please log out and log in once again? Gopal Krishna, sir, I think your internet connection is a little bit weak. We request you to switch off your camera and start speaking.
Hello. Hello, sir. Gopal Krishnan, sir. One thing you can do, log out and log in again, or otherwise you just stop your video and continue with the audio only.
Yeah, that's what I'm doing.
Yes, sir. Now we can able to hear you.
Yes, yes, sir. Yes, sir.
Okay.
We stopped in the region of the kidney biopsy.
Okay. Am I audible now?
Yes, yes, nicely.
Yeah, fine. So a quick run through of the kidney pathologies is that even though the most important pathology is the cause nephropathy, there are quite a good number of a big plethora of pathologies. Am I audible?
Yes, sir. Yes, sir.
Yeah. In the order of priority, like you have already mentioned AL amyloidosis, amyloid, this thing, light chains, they have got the amyloidogenic potential, so that can present as nephrotic syndrome. So in cause nephropathy, the proteinuria will be less, the quantum of proteinuria will be less, there will be a profound kidney dysfunction, failure. Whereas the glomerular pathologies, particularly AL amyloid, and then the whole lot of MIDDs, monoclonal immune deposition diseases, the most common being the light chain deposition disease, and rarely heavy chain deposition disease, and still rarely light and heavy chain deposition disease. All these can have nephrotic range of proteinuria presentation. Okay.
Yes, sir.
So that's so here in cause nephropathy, there will be more of the benzone protein. That is the light chain protein. The contribution of albumin and other proteins will be less than 10% of the total protein. Whereas in the other pathologies, because there is a glomerular pathology, so there is a kind of a massive quantities of albumin and other proteins also can be there, and may not only be a light chain. So that's it. And what are other pathologies? So we are talking about the light chain cause nephropathy, AL amyloid, light chain deposition, heavy chain deposition, light and heavy chain deposition. Anything else?
Sir, apart from deposition, sir, you want to know the MGRS pathology on histopathology?
Please bring it. Don't bring in MGRS. MGRS meaning
Yes.
pathologies, but there is no clear-cut evidence for the malignant potential of the clone. There is evidence for a clone, monoclonal production of this thing, but there is no malignant potential.
Yes,
but your clinical case is a pure multiple myeloma. It is not a smoldering. It's not MGRS. So it is only pure myeloma. So forget about MGRS. The term does not arise at all here. When do you call somebody as having MGRS? In the kidney biopsy, you demonstrate a pathology which is due to a clonal proliferation of plasma cell, but you are not able to demonstrate that because it does not have a tumor potential. It does not satisfy that CRAP criteria. There is no tumor potential. There is no malignant potential there, but still there is evidence for kidney disease. That you call it as MGRS. But here it is a clear-cut myeloma. So what are the other pathologies? Have you heard of PGN-MID?
Yes, sir. PGN-MID can be there.
What do you mean by PGN-MID?
Sir, proliferative glomerulonephritis.
Yeah.
Monoclonal deposits are basically in PGN-MIDD, sir. There we can get, sir, MPGN pattern like deposits can be there. And sir, PGN-MIDD has a classical feature of also immune complex deposition can also be there.
Yeah, in the light microscopy, there can be endocapillary proliferation, there can be mesangial proliferation. Rarely you can have MPGN pattern also.
Yes, sir.
But in the immunofluorescence, what will be there?
Sir, immunofluorescence, we can get, sir, IgG3 kappa deposits are the main we get in PGN-MIDD.
Either lambda or kappa, Okay.
Yes,
So
sir.
then what is the difference between PGN-MID and light and heavy chain deposition disease? In light and heavy chain deposition disease also, in the immunofluorescence, you will have the monoclonal presence of one protein, predominantly IgG, and either kappa or lambda. The same thing is with PGN-MID also. So what is the difference between the two?
Sir, PGN-MIDD has also immune complex deposits are also C3 or C4.
You are right. The light microscopy is entirely different.
Yes, sir. Light microscopy, MPGN pattern and endocapillary proliferation are the presentation in PGN-MIDD.
PGN-MID. But there is, in deposition disease, the cellular proliferation is not there. It's only kind of a deposition. As you rightly said, it can even assume a nodular morphology. Okay, that's the difference. What are the other pathologies?
Other pathologies.
Very important is whenever you come across C3 glomerulopathy in an elderly person and TMA in an elderly person, if you have not ruled out paraproteinemia, your investigation is not complete because in some patients, this paraprotein can cause inhibition of the factor H, and that can result in C3 glomerulopathy. Okay.
Yes, sir.
So C3 glomerulopathy is also a potential pathology in paraproteinemia, particularly myeloma. Okay.
Yes, sir.
What are the other pathologies? Suppose a patient with myeloma presents with phosphaturia, aminosuria, glycosuria.
Fanconi, sir, they can have Fanconi syndrome, like presentation.
It is due to proximal tubulopathy.
Yes,
The
sir.
proximal
Light chain
tubulopathy due to the
proximal tubulopathy.
predominantly tubular dysfunction, presenting as proximal. Okay. Then other pathologies. The crystallopathies. There are crystallopathies like crystal storing histiocytosis, and again predominantly in the tubular pathology, and again crystal globulinemia. And one more important thing is that myeloma can result in type 1 cryoglobulinemia. Okay.
Yes, sir.
Type 1 cryoglobulinemia can present as cryoglobulinemia also. So whenever there is a presentation of cryoglobulinemia, like the rash, arthralgia.
Yes,
That's why I asked what is the importance of arthralgia in this particular patient. Okay, so I thought you will say that, no? But here there is no evidence for that. The typical classical features, like peripheral neuropathy, the rash, and C3 low C4. Okay, that can be the cryoglobulin picture. The cryoglobulinemia is one of the causes here is myeloma, that to type 1. Okay, of course there are other causes for cryoglobulinemia. So there's a wide array of presentations. Is the therapy of myeloma can cause kidney injury? Therapy per se can cause kidney injury in myeloma?
Yes, sir. Bisphosphonates can be nephrotoxic also.
Okay. Then,
Plus, sir, many chemotherapy agents, they also need renal clearance, like sir, cyclophosphamide.
this is myeloma causes thrombotic microangiopathy. Can cause thrombotic microangiopathy.
Sir, I could not hear.
No, which drug used in myeloma can cause thrombotic microangiopathy?
Sir, carfilzomib can cause TMA-like presentation.
Rarely bortezomib also, but fortunately it is rare. But carfilzomib, a better version of bortezomib,
Yes.
there are reports of TMA. And what is the nephrotoxicity? Rarely due to lenalidomide.
Yes, sir.
What is the pathology due to lenalidomide? It can cause acute interstitial nephritis. Fortunately, it can cause acute interstitial nephritis.
Yes, sir.
Okay, fine. Fortunately, it is rare. Okay, now tell me, coming on to this particular patient's management. The patient has got renal failure, probably myeloma-related pathology. In all probability, it is a cause nephropathy, and the free light chain is very high. What will be your plan of action now? How will you manage him?
Sir, first, I would, sir, this patient first we need to take care of the supportive treatment to maintain the renal perfusion, like hydration and hypercalcemia. But this patient, sir, particularly was not having good renal function and oliguria, sir. So this patient was managed with hemodialysis.
Okay.
And sir, apart from chemotherapy, from hemodialysis, sir, we started on chemotherapy. It was given the, sir, basically we have given the cyborg regimen.
Okay. Anything else you will do considering the light chain burden?
Sir, light chain burden, sir, this patient already, sir, window time has passed, but as per theory, we can, sir, use a high cutoff dialyzer can be used if the patient is presenting with high tumor burden, more than light chain, more than, sir, 1000 milligram per deciliter if the patient is presenting within 2 to 3 weeks.
So what are the extracorporeal therapies that can cause removal of the free light chains?
Sir, high cutoff dialyzer is one thing. Sir, Plex has been studied, but it is not of much benefit seen. And
okay, so what do you mean by high cutoff hemodialysis?
Sir, high cutoff dialyzers where we use big pore sizes of around 60 to 65 kilodaltons, where the light chains having a molecular weight of 22 and 45, they are effectively cleared. But sir, side effect is the albumin loss is seen in high cutoff dialyzers.
You are right. So the conventional dialysis, then little more pore size of the membrane is your high flux dialysis. And then next is the medium cutoff dialysis and then high cutoff dialysis.
Yes, sir.
The high cutoff dialysis can remove substances with a molecular weight of even up to 60 kilodaltons.
Yes, sir.
As you rightly said, the kappa light chain's molecular weight is 22.5 kilodalton and that of lambda is 25 kilodalton. So obviously your high flux dialysis cannot remove this, whereas high cutoff dialysis can remove. And as you rightly said, plasmapheresis, there's conflicting reports. There is no clear-cut evidence to show that. Why this is important? Because Dr. Pratik Das mentioned, like the most important factor in causing kidney injury is the light chain. So that is causing the havoc. So we are supposed to remove the light chain burden from the body. Okay, so that is it. So can you name the more important two activities which have employed the high cutoff dialysis in myeloma?
Sir, I could not hear.
No, what are the two RCTs, randomized control trials?
Regarding sir, high cutoff dialyzer, two big RCTs were Meyer trial and Ulite trial. Sir, but both of the trials at the end of 3 months, hemodialysis independency was not at all seen. Plus, with the more use of high cutoff dialyzer, there was more chances of infection was seen in Ulite trial, sir.
Yeah, Ulite trial clearly showed absolutely there is no benefit.
No benefit.
On the other hand, increased mortality was reported in some of them.
Yes, sir.
But the Meyer trial, even though that at 3 months, dialysis independent state was not significantly different from the patients who underwent a conventional dialysis. At 6 months and 12 months, the dialysis independence was better in Meyer's trial. What are the essential difference between why these two? What are the essential difference between these two trials? Was there any important difference in terms of the high cutoff dialysis that was offered to patients in these two trials?
Sir, I don't know.
In Meyer trial, actually, the high cutoff dialysis duration was limited to only 5 hours. Whereas in Ulite, it was extended up to 8 hours with the purpose of reducing more and more. So probably that resulted in more infections and so on. So even though we don't have any solid evidence for high cutoff dialysis, but still you cannot just neglect that. Wherever it is available in a particular center has got it, it has to be judiciously used. But not at this stage. This gentleman is already on dialysis for 4 or 5 months. So the prevention of permanent kidney injury can happen, or mitigation of the permanent kidney injury can happen only if the free light chain is dealt with very early. The initiation of high cutoff dialysis has to be early, not at this stage.
Yes,
okay, so that is out of question. So what is the chemotherapy that this patient is on?
Sir, this patient was given bortezomib based, bortezomib, cyclophosphamide, and dexamethasone combination was there. But sir, in today's first line therapy, we also daratumumab has to be added for better renal recovery.
But that is called quadruple therapy.
Sir.
So what is daratumumab?
It's an anti-CD38 monoclonal antibody against plasma cells.
Yeah. So now currently the quadruple therapy in employing daratumumab is supposed to be the standard of care therapy. Okay.
Yes,
a combination of daratumumab, bortezomib, dexamethasone, and
cyclophosphamide.
Cyclophosphamide or lenalidomide.
Yes, sir.
If cyclophosphamide is not given, lenalidomide is given. Okay. So that's it. So thalidomide is given up, and the initial therapies of cisplatin and other drugs, the conventional drugs, melphalan, all that is given. So this is the current treatment regimen. Okay. So how do you prognosticate him? Is there any possibility that with this therapy, he will come out of the kidney failure or not?
Sir, for prognostication, we need to first clinical recovery is there, renal recovery, sir. We need to look after, and second thing, sir, hematological recovery also we need to follow up. So for that, we need to follow up with serum FLC every 2 to 4 weeks, along with SFLC and ratio, and sir, in very stringent cases, if the patient is planning to undergo renal transplant, then that time we can also do bone marrow to check for stringent remission.
No, in him already 5 months he's on dialysis. Renal recovery. I think it is. I don't think it is possible.
Yes, sir, not satisfied.
So, in general, how do they give therapy? This therapy is given in cycles.
Yes, sir.
So yeah. So there are some people based on keeping the serum free light chain as a target. It has to come down to less than 30% of the baseline and so on. Keeping that target, the number of cycles is decided. Okay.
Yes, sir.
So I think how many cycles he received, and again, free light chain was measured. Again, we don't know. And because of renal failure, again, whenever there is renal failure, the free light chain gets accumulated and it goes on. So that is why the presence of renal failure by itself is an independent poor prognostic factor in myeloma. No, because that will add up the free light chain burden in the system because of the impediment in the excretion of that. Okay, fine. So what is the long-term course for him? Suppose if he says that, is he a candidate for kidney transplant? Suppose if you have done a biopsy and that shows the permanency of the pathology and if he's dialysis dependent, is there any option for kidney transplant in him?
Yes, sir. With the proper prognosis and explaining the recurrence rate to the patient can be taken for kidney transplant. But sir, nowadays even the new
for kidney transplant, you should achieve hematological remission.
Yes, sir. Hematological remission for 6 to 12 months. And sir, nowadays also the bone marrow transplantation has also become the standard of care, followed by kidney transplantation.
So what type of stem cell transplant is it? Autologous or allogenic?
Sir, autologous stem cell transplantation is considered because less immunosuppression and it has a better survival, but sir, relapse rate is higher.
Okay, fine. Okay. Is there any other therapy? The recent therapy for myeloma, those where there is a refractory and difficult to control and relapsing myeloma, is there any other therapeutic option?
Sir, apart from these conventional, sir, newer we can have a CAR.
Very good. Yeah, very good.
Therapy is there. Or anti-BCMA, sir, drugs are also coming up in the future.
What is CAR T cell therapy? What is CAR T cell?
Sir, it is a engineered autologous T cell against the anti-BCMA antibodies. Anti-BCMA.
Antigen receptor. Chimeric antigen receptor T cells. The engineered cells.
Yes.
The cells are engineered in such a way that they go and bind with the particular antigens on the neoplastic cells, and then they are handled and they are mitigated. They are neutralized. That kind of a therapy. Okay, it's evolving for many kidney diseases as well, including lupus nephritis, oncovasculitis, and so on. Primarily, it was started for malignancies like myeloma, and now the non-malignant conditions also it's happening. It's very exciting time we are passing through. What are the complications of bortezomib?
Sir, bortezomib main complication is neuropathy. Second, it can have a cardiac toxicity also. It can have thrombosis or DVT. Plus, sir, they can also have thrombocytopenia.
Right. Would you advocate aspirin prophylaxis and anticoagulation prophylaxis?
Yes, sir, since they have a very high risk of thrombosis, aspirin.
Some centers routinely give prophylaxis also. Okay. So, what are the complications of lenalidomide?
Sir, lenalidomide, sir, same neuropathy is there.
And it causes thrombocytopenia.
Yeah,
can be there.
Bone marrow suppression is more with lenalidomide, especially thrombocytopenia is there.
Yeah. Lenalidomide can cause complete alopecia in some of them. And already I've mentioned lenalidomide can cause acute interstitial nephritis in some people as well. Okay, so why I'm asking is that none of these therapies is absolutely safe, and you have to be extremely careful in monitoring the side effects as well. Okay. If the bone pain is continuing, anything else you can do as an adjuvant therapy,
Sir,
as a supportive therapy?
sir, just excuse me, sir. Just
For bone pain, handling bone pain, anything else can be done.
sir, for bone pain, we can give bisphosphonates.
Okay, bisphosphonates. Which bisphosphonates you give?
Sir, in bisphosphonates, sir, palmidronate are the drug of choice. Although, sir, they has to be taken. The drug reduction should be there. And second, sir, zoledronic acid can also be given, but it is contraindicated if the creatinine clearance is less than 30.
So again, palmidronate, can you safely give in the presence of kidney failure?
Yes, sir.
Now again, dose modifications required.
Dose
and so
modification required for sir palmidronate and zoledronic contraindicated less than 30.
Okay, this can you give bisphosphonate when somebody's parathormone is only 14? If I remember right, you
Yes,
mentioned
yes, sir.
PTH is so low.
No, sir.
Yeah, it's very difficult, These bisphosphonates, they can result in dynamism, right?
Yes, sir.
Yeah. How about denosumab?
Denosumab, sir, can be given in the patient with renal failure of all stages.
Yeah, exactly. So if this gentleman's hypercalcemia is continuing, and if there is bone pain, and denosumab is one choice, So how do you give denosumab? What is denosumab?
Sir, denosumab is rank ligand inhibitor. It inhibits the osteoclastic activation by inhibiting the rank ligand. Denosumab can be, sir, given as subcutaneous or nasal spray. Dose is, sir, around 120 milligram.
60 milligram, 60 milligram.
Yes, sir.
So this is
Monthly.
bisphosphonates therapy. So this is very important because it can cause a dynamism. Okay, and similarly, denosumab also, it can lead on to hypocalcemia. Yeah, you have to monitor, right? But in this gentleman, it cannot happen so easily because he has been hypercalcemic. Okay.
Yes.
So in the dialysis prescription, anything else, you'll be very particular in this gentleman because his calcium is very high. You will use a different dialysate?
Low dialysate calcium, sir, can be used.
Yeah, that can be used. Okay, fine. So how is his diabetic control now?
So presently patient is well controlled on only one DPP inhibitor. He is only receiving Ondero with sir only long acting, sorry sir, short acting atropine he is receiving.
Okay. So now retrospectively thinking, do you think you could have done a kidney biopsy to start with itself?
Sir, actually kidney biopsy, the patient was sir having all the multiple myeloma criteria with fulfilling CRAB criteria. So directly we started on chemotherapy. But sir, in cases where we have a suspicion of dual pathology, in that case, sir, we can go for kidney biopsy.
Okay. So this is a clear-cut situation of a non-diabetic kidney pathology in a diabetic, right? The absence of retinopathy, right?
Yes, sir.
And no evidence of proteinuria. Okay. And the clinical the kidney failure presenting as an acute presentation following an infection and drag. So no diabetic nephropathy features are there in general. In such a situation, we go for kidney biopsy. But here, probably he was severely anemic and he was very ill and not fit for. Most of the times they have thrombocytopenia as well and so on. Okay. Fine. So what are the other paraproteinemias?
Sir, other paraproteinemias, sir, if we histologically, if we will define, sir, depending upon the monoclonal deposition or non-monoclonal. In non-monoclonal, we have TMA, C3GN, and POEM syndrome. In the monoclonal, if we divide it into the sir organized and non-organized deposits. In non-organized, we have PGN-MIDD and MIDD, and in sir organized, if they are having fibrillar arrangement is there, then they can have amyloidosis, and if fibrillary GN can be there. If the patient is, sir, having microtubular arrangement, then the patient can have immunotactoid glomerulonephritis along with sir, cryoglobulinemia. or sir, patient can have a crystalline deposits also they can present in light chain proximal tubulopathy.
No, these are all pathologies.
Yes,
The
sir.
other paraproteinemias are Waldenstrom's macroglobulinemia, right?
Yes, sir.
Yeah, that also is a paraproteinemia. The problem there is a very high chance for hyperviscosity syndrome. Okay,
Yes, sir.
hyperviscosity syndrome in myeloma, frank myeloma, we don't get very often unless the tumor burden is FLC burden is very high. Normally, we don't get that. Whereas in Waldenstrom's macroglobulinemia, it's rare, and the hyperviscosity syndrome potential is very high. Okay.
Yes, sir.
Fine. So, a little bit of general questions. What will be the acid-base disturbances and electrolyte disturbances in myeloma?
Sir, because of
Before development of kidney failure, without kidney failure.
sir, there can be proximal tubular defect, because of which there can be hypouricemia, hypophosphatemia. There can be hyponatremia. All these things can be there because of the sir,
Hyponatremia or pseudo-hyponatremia in myeloma.
Yes, sir.
Why is it called pseudo-hyponatremia?
Sir, because it adjusts with the albumin, low albumin.
No. What are the other causes for pseudo-hyponatremia apart from myeloma?
Sir, pseudo-hyponatremia can be seen in the presence of, sir, hyperglycemia.
Yeah, severe hyperglycemia and hyperproteinemia.
And
Okay.
yes, sir. And
but nowadays, with the ion selective electrode and all that, it's not that common. Okay, what happens to the anion gap, plasma anion gap in myeloma when there is no renal failure?
there is, sir, a bicarbonate loss is there. So it's not low anion gap.
Renal involvement is not there, I asked.
Sorry, sir.
Low anion gap because these light chains, they have cationic charges, right?
Yes, sir.
So this is where you get a low anion gap and pseudo-hyponatremia. So that's about myeloma. Okay. And the point of interest here is that recently there is a change in the epidemiological profile of the patients. In the past, it's a disease of the elderly, and we will not entertain a possibility of myeloma in patients less than 60 years in the past. Now all that is just gone. Now more and more of younger patients we do come across. In our department in MMC, we have come across myeloma even in a 27-year-old gentleman. So, but still it is a disease of the elderly, still, but now, so that clinical suspicion is very important.
Yes.
The inexplicable anemia, inexplicable hypercalcemia when the parathormone is even low, and there's a bone pain and all that, you have to think in terms of paraproteinemia. So that's it. Okay. Fine. Anything else you would like to discuss? So the kidney pathology. So it's very interesting, and the variegated kidney pathology in myeloma, and MGRS as well. Almost there are also more such pathologies too there, and whereas in MGRS, actually PG and MID is little more compared to myeloma. And classical myeloma, you get cause nephropathy, and again, in a given patient, you can have more pathologies, double pathologies and triple pathologies. The combination will be cause nephropathy and light chain deposition disease, a cause nephropathy with proximal tubulopathy, that kind of a thing. Very often you come across that as well, a combination. And whenever you come across a patient with myeloma with kidney dysfunction, immediately what you have to do is that assess the hydration status, because these people are highly vulnerable for hypovolemia because of polyuria and poor intake. Polyuria because of hypercalcemia. So correction of hydration is very important. First step. And then remedial measures for hypercalcemia. So how do you treat hypercalcemia?
Sir, hypercalcemia, first we have to give with the IV hydration followed by bisphosphonates, denosumab, and in severe hypercalcemia we can also give steroids and calcitonin.
IV hydration, particularly with 0.9% saline.
0.9% saline, sir.
And there is no role for furosemide. Initially, we thought furosemide really helps, but actually, there is no evidence furosemide helps. It's enough if you just give 0.9% saline, and then stepwise you go high. So, because hypercalcemia per se can cause acute kidney injury, it causes the vasoconstriction of the afferent arteriole. And if this hypercalcemia is uncorrected, it goes in for chronic tubular interstitial pathology that results in polyuria. Okay.
Yes, sir.
Yeah. And so hypercalcemia per se can be a cause for polyuria. So it can cause chronic tubular interstitial nephropathy. Like your hypokalemia, chronic hypokalemia also causes chronic tubular interstitial pathology, and hypercalcemia also. It's called hypercalcemic nephropathy. And then infections, because these people are inherently vulnerable for infection. This is a paradox, right?
Yes,
You
sir.
have increased immunoglobulin, but the vulnerability for infection is pretty high because it is not efficient in handling the infections. And of course, you will have cytopenias. So infection, and then the drugs given for infection. So all these four things are the important causes. So they have to be very, very diligently addressed. In spite of all these, if there is kidney failure continuing and the free light chain is more than 150 milligram per deciliter, you are dealing with a patient with, certainly you are dealing with a patient with cause nephropathy. Okay, that's it. You can, if the patient is not fit to undergo biopsy, you can straight away start therapy, because initiation of therapy is very important. Early initiation of therapy is very important because, the early removal of the free light chain as well as mitigating the cause for the free light chain. So that is very important. If it is missed, the initiation of treatment is missed, there will be permanency of the kidney pathology. That's what is the current observation. And there are some centers in India where we don't have this high cutoff dialysis facility. Still, they adopt a treatment algorithm of plasmapheresis, whatever birth it is. You have to give 5 to 7 sessions of plasmapheresis over a period of 10 days. As you have nicely mentioned, it is very risky because that by itself can lead on to vulnerability for infections and coagulopathy and so on. But still, why it was given up, why it is not favored, because plasmapheresis is not that efficient. Even though it brings down the FLC level, it is not that efficient to achieve the target free light chain levels, to bring it to an acceptable level. So on the other hand, you have to, if the infectious complications is more, that can result in morbidity and mortality as well. So that's it. But still, many centers, as a routine, they give. If high cutoff dialysis facility is there, even though there is no solid evidence based on the two major RCTs, but still the people who are working with myeloma, they suggest that you have to give high cutoff dialysis because the purpose is that you remove FLC. Okay, that's it. And anything else? Why there is hypercalcemia in myeloma?
Sir, because of the osteoclastic resorption, and it is a PTH independent hypercalcemia.
Yeah, it's a osteoclastic resorption. Osteoclasts liberate. It causes simply the lysis of the cells,
Yes, sir.
Lysis of the cells by liberating hydrogen ions into the microenvironment, and that causes dissolution of the cells. And so the from the bone, the calcium comes out.
Yes, sir.
So that's it. So what is the classical description of the X-ray of the skull in myeloma?
Sir, punched out lesions are seen in the flat, long bones of the flat bones are in the flat bones, sir. Punched out lesions.
The moth-eaten appearance,
Yes, sir.
the moth-eaten appearance of the skull. Okay, now, so those descriptions were important in the ester years because, there is no widespread availability of our other investigations. And it's good that you have done fish. What is the utility of this fish in this scenario?
Sir,
How does it help us?
sir, fish is actually to determine the high risk patients.
Exactly.
Cytogenetics are positive for deletion of 17p, gain of 1q chromosome, or the translocation of 14q. They are the very high risk patients.
Based on this, the patients are categorized. Apart from the parameters, other parameters of free light chain assay and the involvement of the kidney and severity of anemia and so on, the fish characteristics also, the cytogenetic abnormalities also aid in classifying the patients as high risk and so on. Based on that, your therapy can be modified. The number of cycles can be increased, and you can take a decision to go for high cutoff dialysis and so on. Because if you are sure that you are dealing with a high risk patient, so in that way it really helps. Okay, fine. And again, we have to understand the limitations of the serum protein electrophoresis and urine protein electrophoresis. It is not, it's only a screening kind of a thing, it's a preliminary thing.
Yes, sir.
Wherever it's uncertain, you have to go for immunofixation. So that is more sensitive and specific. And again, free light chain ratio, kappa lambda ratio is more important. Because the free light chain assay can be increased. To prove the monoclonality, the ratio alteration is important. There are certain conditions, non-myeloma conditions, where there is increased production of immunoglobulin. There is a non-specific B cell activation, even in HIV and conditions like sarcoidosis and so on. There can be hypergamma globulinemia. So naturally, the free light chain can be more in the concentration. But there, the ratio is not altered. So that is why we talk about ratio, then only the monoclonality is identified. And again, in the kidney biopsy, the previous decades, we were not specifically looking for the light chains in the biopsy. But now it has become a routine practice. There are many instances, clinically we might not have suspected a paraproteinemia, but after kidney biopsy, where there is a light chain restriction. What do you mean by light chain restriction?
Sir, in the IF, if there is kappa or lambda chain restriction?
Either kappa or lambda present. So the light chain restriction gives a clue that you are dealing with a paraproteinemia, and then any number of instances we do come across that way. Okay.
Yes, sir.
So in general, in AL amyloidosis, which is the dominant free light chain usually?
Sir, lambda chains are predominant.
Usually the kappa in cast nephropathy and lambda AL amyloid. Okay, fine. So in AL amyloidosis, which are the other organ systems that can be affected?
Sir, heart can be affected in the form of restrictive cardiomyopathy. Second, sir, liver, there can be hepatosplenomegaly. Their nerves can be affected in the form of peripheral neuropathy can be there. Sir, in the GI system, the patient can have constipation or gastroparesis-like symptoms can be there. Sir, apart from that, they can have a classical feature of macroglossia or periorbital purpura can be there, but it is a sir rare.
Okay, fine. And in the extracorporeal therapy, is there one more newer thinking to remove FLCs apart from high cutoff? Use of PMMA. What is PMMA? The polymethyl methacrylate membrane.
Acrylate membrane.
Yeah, using dialysis with the PMMA, that causes adsorption of the free light chain. And there is one nice publication, like what do they do is that they initiate hemodialysis with PMMA. After 2 hours, they change the dialyzer because it might get clogged with so much of adherent like free light chain. So change the dialyzer once again, and they have shown it's a kind of a heme adsorption.
Yes.
So that also is being tried. There are other novel extracorporeal therapies also. Let us be hoping sincerely for emergence of some real good extracorporeal therapy for removal of that. So please remember that also.
Yes,
Heme absorption with polymethyl methacrylate. Okay. And in our own department, actually, one of our patients with light chain deposition disease on chronic maintenance dialysis therapy, he underwent a successful HSCT, hematopoietic stem cell transplant. And the disease was in, of course, the kidney failure did not improve, but the disease was in remission. So the more and more of hematopoietic stem cell transplant also is happening with multiple myeloma in many centers. And the CAR T cell therapy is the newer excitement in this. Okay, fine. So thank you. It was most of the questions you answered well, and just go through whatever the discussion went on. And
okay, thank you very much, sir.
Yeah, good. Thank you.
Thank you, sir, for this nice and extensive discussion. Although some technical glitches were there, but we have also learned a lot from this class. The two things we need: one, the assessment of the student that have already given, whether she should pass in the examination or not. And second part is just my job is to make a small summary of the class, what you have told.
Yeah, It's a clear pass. Why there is a doubt. She has passed, certainly. Certainly she has passed. And I'll tell you something like, the clinical nephrology and clinical medicine. It's a vast ocean. Nobody can answer all the questions. And the purpose of examination is that, whether the candidate has some insight into the problem, is able to understand the problem, comprehend the problem, list out the problems, and then chalk out a treatment strategy. As simple as that. So the DM examination is different from the undergraduate and the postgraduate examination. It's more of a discussion rather than a question answer session. I feel so, and that way I think definitely she's okay. But there are certain areas where there is scope for improvement, but definitely she has done well. I wish her well in the exams too.
Thank you very much, sir.
And again, please remember, exam is just yet another day. There's a lot of hype about exams, and don't learn anything for the sake of exam alone. And also a tip is that, on the day of examination, you have to be totally relaxed. And you should feel that you are entering into ward like yet another working day. If you have that mindset, your performance will be the best. No need to have any kind of a different kind of a thought process and anxiety and all that. Have a nice sleep the previous day and without skipping breakfast, well hydrated and very relaxed, because so these discussions, the questions can be, you may have to answer some questions based on your remote memory also. It is not just what you learned the previous evening. No, not at all. Because the discussion can just go on anywhere. For instance, I asked you about autonomic neuropathy. Is it not? So be very specific, like they think like a physician as well as a nephrologist, like you do in workup of every patient. The complete assessment. It is not only the kind of physical symptom analysis and physical findings, chalking out the differential diagnosis and then arguing for and against every possibility. And then without forgetting about the physical, the functional ability, and where rehabilitation is required, and talking about emotional support and social support, little bit of family, all that is important in nephrology, because renal replacement therapy, meaning the entire family has to be counseled. So if you add those points, also are very important. That's why I wanted in the presentation about his family and who is taking care of him, and the little bit of economic status, and where is he hailing from, where is he residing, what will be if you plan something for a long term, whether it will be okay for him, and the functional capacity, whether he can go for work in between dialysis or still it's not reached that stage. All that is important. So you don't think that it will take a lot of time if you elaborate on all these things. You prepare the presentation in a nice format so that in 1 or 2 sentences, all these comprehensive information can be kind of presented. It comes just by practice. That's all.
Yes,
and you take an elaborate history, but when you present, actually you should know where to prune. Unwanted things can just be pruned and let out, and you summarize, cluster the negative histories in 1 or 2 sentences and finish that one. And whenever a patient is on dialysis also, without forgetting how he is tolerating, what is the prescription of dialysis, like for instance, twice weekly or thrice weekly dialysis, and no reuse, and 4 hours each, no interdilatic hypotension, by and large he tolerates well, that kind of a thing. So if you it wouldn't take more than 10 seconds to describe completely what's happening in the dialysis, right? So like that. So that is very important. And again, clinical examination, be very thorough. There are some examiners who are very particular to elicit findings, and for instance, you mentioned about ejection systolic murmur in pulmonary area. Deliberately, I left that discussion because honestly that lead on to a different direction. But the same thing, may not be true with another examiner. They may be just probing on that. So the physical examination be very thorough. There are some examiners, they will say just tell only positive findings. So you should not get flabbergasted. You be ready for that as well. If you are asked to present only positive findings, you should be able to say that. If you are asked to present elaborately, again, you should be able to do that. So for all this is possible only when you are very confident and comfortable and cheerful on that day, without any anxiety. No need to be anxious. Absolutely no need, because you have worked so hot for 3 years and you have a basic understanding of all the diseases. And again, when you are not able to answer a question, don't get upset. I mean, you should be able to quickly come out of that. That should not be lingering on in your response to other queries and other questions. That's very important. If you are not able to recollect, you can simply say, I mean, I've learned that, but I'm not able to recollect. If you say that quickly, the examiner will move on to the next question. So don't allow a silent pause for a long time. So that's another thing. Because sometimes, it's very difficult to remember the dose of a particular drug, the classical regimen and so on. And those things will not be taken very seriously. So what is ultimately is expected is that understanding of the problem you are dealing with, that's more important. And ability to chalk out a reasonable management strategy on par with the existing standard of care. These are the two important things. And in between, even though it's a clinical discussion, I have checked your knowledge in the basic sciences and basic diseases. Indirectly, some questions will be here and there. So with those questions, we'll be able to gauge your understanding of the basic concepts. So there should not be any kind of a flaw, any kind of a shortcoming in the basic understanding of the basic concepts. So that is what, these are the things expected. Nobody expects, like you have to be 100% answering all those questions and so on. If you are able to answer, that is very well, and that's good. But it doesn't mean that it has to be there. And in my assessment, you have done fairly well in a clear pause. Okay.
Thank you very much, sir, for the feedback.
Okay. So thank you, sir, for this nice explanation and advices that will be good for the students. Just I have just to give a small summary of the class. Dr. Pallavi, your sir has asked to go slightly in detail about the personal history regarding his married life and the professional life, how many childs, and whether this has a bearing on the disease or not. And in the next question, he has asked, you have told that is a large volume of urine, why there should be a large volume of urine in diabetes. What are the other probabilities? Because how commonly you get an polyuria in a diabetic patient, because there was no edema, no frothy urine, and there is no oliguria. So there was no clue regarding your diagnosis, one of the diagnoses of diabetic nephropathy in these patients. He has also asked about this nature of urinary changes, like nocturia, that is more common. And in the next part is a liver abscess. He has asked how do you explain the liver abscess in this patient, because he is not an alcoholic. That happens patient mostly develop this amoebic liver abscess. What are the other causes you look for this pyogenic liver abscess, like an Klebsiella pneumoniae, world of pneumonia, or an endocarditis, and especially a patient coming from countries like this part of the world, they can develop miliary disease, and they have a same kind of abscesses without any evidence of endocarditis and without any non-alcoholic patient. Then thirdly, he has asked you about the sepsis. You have told the sepsis has probably precipitated. So what are the natural outcome of the sepsis? What is an AKI, and AKI, how does it convert it into CKD, in between AKI, AKD, CKD consequences? And he has also asked you regarding the mechanism, how the sepsis causes an acute renal failure, hemodynamic causes and non-hemodynamic causes. And he has also asked about any anti-diabetic drug which cause, like SGLT2 inhibitor. In some patients, they can cause a increase in polyuria. And in these patients, AKI to AKD to CKD may be a simple causes without involving the diabetic disease, but diabetic CKD may be a probability. In the third part, in cases told that this patient had an anemia, and asked about the different causes of anemia in the dialysis patient, so who is warranting the transfusion, like the deficiency causes blood losses. Yeah, and this is a severe hyperparathyroid is an important cause, which causes marrow fibrosis. There may be functional iron deficiency, and also you need to exclude the infections like tuberculosis as well as the malignancies. In cases, the ferritin and transferrin saturation test is important. Although there's a ferritin maybe and functionally may be high in presence of inflammations, you should have a low threshold regarding doing an endoscopy when you are suspecting the GI blood loss. And then he has asked about this severe bone pain, what the probable causes of bone pain in a patient who is on dialysis. And already you have told the high turnover bone disease, but he reminded you that maybe some low turnover or dynamic bone disease may also be very painful. And then he has taken a lots of insights. He has asked you how the NSAID can cause a renal failure, hemodynamic way, acute interstitial nephritis, or maybe chronic interstitial nephritis. And this part that have been discussed in your history. And in the examination part, so in the examination part, regarding asked about regarding the presence of this retinopathy, what percent of concordance you get in present in a nephropathy retinopathy consortium, and whether the absence of retinopathy exclude this nephropathy or not, and how do you examine, did you examine the neuropathy, and what are the possible things additionally do to exclude this macro and the microvascular changes like peripheral pulses, your claudication signs, as well as the reflexes, and how the patient was investigated. And you told that there was an M band in the beta region, but he corrected that it should be a gamma globulin, it should be in the gamma region, and this probably may be a beta 2 microglobulin. To confirm this and to avoid to clear out this confusion, immunofixation electrophoresis is a better option, which fixes the protein and is a more sensitive and a specific one. Then he has asked you how to proceed for this patient, and this is will you perform a kidney biopsy in such patients, and in these patients whether what should be the pathology you are expecting, and you told that rightly the cast nephropathy you are expecting. And then he asked what are the probable other things you are expecting, you can expect in the biopsy, and in the biopsy how does it look actually. And in the subsequent part, then he has asked you regarding this last one. Other pathologies like he has asked you like amyloidosis is a light chain deposition disease, heavy chain deposition disease, and combination of light chain and the heavy chain, where the albuminuria is the predominant component. They present with nephrotic syndrome, whereas cast nephropathy they present with severe renal failure, but less of an albuminuria, and light chain is the important cause for that. And he has asked you about this, what is an PGN MIT, what do you get in light microscopy, some kind of proliferation, maybe mesenchymal, maybe endocapillary, maybe an MPGN pattern. But in the immunofluorescence study, you get a lambda or the kappa, that is a predominant depositions. Here there is a discussion regarding the MGRS. He told you the MGRS is a disease of disease with a clonal proliferation, but that doesn't have a tumor or a malignant potential. Renal involvement is there, but multiple myeloma cannot be diagnosed by this conventional criteria. So this clone doesn't have the malignant or the tumor potential. He has asked you between the difference between the MIDD and the PGN MID. And it will that is this is cellular proliferation is an important part of the PGN MID, which is not there in MIDD. And what are the other pathogenic features that you get? Yes, if an elderly patient goes on low C3, and C3 glomerulopathy can be a sole manifestation of a multiple myeloma. He has also asked how it happens, because paraproteins inhibits the factor E that leads to C3 glomerulopathy. And also if a patient presents with the phosphaturia, glycosuria, amino aciduria, what do you think? Rightly told that my proximal tubulopathy. And he also reminded you this kind of patients may have a type 1 cryoglobulinemia, present with rashes, arthralgia, or maybe a low C4 level. And the crystallopathy also they can present with the tubulopathies. And some cases we can get a TMA, particularly related to the drugs. Bortezomib is one drug that may be associated with the tubulopathy. And therapy also can cause some kind of renal damages like lenalidomide. They can cause this is an acute interstitial nephritis. In the management part, he has asked you how to manage these patients in considering the very high level of the light chain and what are the ways of removal of the light chain. Here there is a discussion about high cutoff dialysis, and what is the, if you rate it, there's a hemodialysis followed by high flux, followed by medium cutoff, followed by HCF, and is a higher port size that clears the light chains of around 40 kilodaltons, and is a 60 kilodalton they can clear out. And another way to remove is the plasmapheresis. He has asked two important randomized control trial on this HCF. You rightly told this ELUTE and the SMILE trial. And he asked you about the differences. In the ELUTE trial, there is no benefit in the mortality in this clear no benefit. And the Maya trial, this dialysis independence and etc. was not different, but there is some initial benefits was shown. Essential difference between the two trials, there's Meyer made the duration of dialysis was only 5 hours, and ELUTE this was 8 hours. So there may be a chance of more infections like that. And this is a presentation of the kidney. These patients, these kind of dialysis were not probably of help, because it should be started very early, because you want to prevent the development of the kidney disease. In the next part, in the chemotherapy, he has asked you what is a daratumumab and what is the quadruple drug therapy. The standard of care of today is a combinations of a dexacyclo or maybe lenalidomide along with bortezomib and daratumumab, you have rightly told. And he has asked you how to prognosticate the cases, and because whether this patient will improve or not, duration is important. Presence of renal failure is an independent risk factor for this, and you target your chemotherapy cycle in targeting the free light chain. If it is less than 30%, accordingly you decide how many cycles you to give to cause an remission. Okay. Then he asked you about what are the candidates for the kidney transplantation, whether this patient can be done or not, and what is the relationship between the bone marrow transplantation and kidney transplantation, to the sequential or not, whether this is an autologous or allogenic bone marrow transplantation if you at all do in these patients, and any other different any therapy that is for these difficult cases which is not responding to the standard 4 drug therapies. And you rightly told about this CAR T cell therapies, and the mechanism of making a CAR T cell is a genetically engineered T cell, which is actually helps in so many kidney diseases like lupus nephritis, and also in some transplant cases, and also in these cases. He asked about the complications of the bortezomib, and as well as the complications of the lenalidomide, like an alopecia. It can cause a complete alopecia, it can cause interstitial nephritis, it can cause peripheral neuropathies. And then he has asked you about this. He has asked you about what is the cause of this bone pain of such patients, and what should you do for this bone pain. Bisphosphonates is the one of the right answer. And pamidronate, you are already told it needs some modifications of the dosage. You cannot give a zoledronic acid. Can you give a bisphosphonates in this patient who has a very low PTH level? And he has questioned you. You should look for PTH before prescribing. This is because these drugs can precipitate dynamicity. And what is the denosumab? Whether this can be given or not in a patient having a severe bone pain, some sort of osteoporosis, and this is a hypercalcemia is there. And so you can give a denosumab, and we asked about the mechanism of denosumab and how it is given in every 6 months subcutaneous doses in 16 milligram doses. And then we asked about this next part in the how to prescribe dialysis in such patients, whether you can change the dialysate or not. And here the low calcium dialysate was an option. And also regarding the need of the kidney biopsy for this particular patient, because this patient had diabetes for quite a long time. At the same time, he has at the same time multiple myeloma. So as there was no proteinuria, there is no retinopathy, there was a polyuria was there, and there's an acute deterioration, and infection has precipitated. All this suggests there may be a non-diabetic kidney disease in these patients. So he has asked about what are the other types of paraproteinemia, like Waldenstrom macroglobulinemia, that you need to know. And this is what are the electrolyte disturbances in multiple myeloma. And in the normal renal function patients, you can get a pseudo hyponatremia along with a low anion gap metabolic acidosis. And he asked what are the other causes of pseudo hyponatremia other than this multiple myeloma, whether how the epidemiology has changed over the years in the myeloma patients, because more and more younger patients are now developing, and you cannot suspect even then you can get a myeloma patients. And once you get a myeloma diagnosis, you should assess the hydration, because the correction of hydration can prevent so many things. And at the same time, he has asked the correction, hypercalcemia is an important thing which can be corrected by 0.9% normal saline, unlike to that of previously tried with the other fluid. Because hypercalcemia, if it persists, it causes vasoconstriction, At the same time, acute kidney injury followed by interstitial nephritis, and it can progress to CKD event. Then important second part, you look for any infections, because it is a paradox that there is an increased immunoglobulin, but still there is an infection. Because these immunoglobulins are not effective in controlling the infection, that should take cover. So once you correct these factors like infection, dehydration, and this hypercalcemia, and still your level of light chain is more than 150, then you should seriously consider of a cast nephropathy and you should start a therapy, because early starting of the therapy is very important. He has clearly emphasized on this early initiation of the therapy. Whatever therapy you should start early, like that of a high cut-off dialysis, or in some centers, in spite of lack of evidences, practices plasmapheresis for very early and to remove these light chains. And this is then is asked about, lastly, he has asked about this where there is a hypercalcemia, multiple myeloma, then yes, this is an osteoclastic lysis of the osteoclast that you have rightly told. And what is the classical X-ray descriptions of the myeloma, like a moth-eaten appearance he has described. You should remember these terminologies also. And utility of this fish study here, whether how it is helpful. He has rightly mentioned that yes, it should, you can categorize the patient, you can plan your therapy, and and you can prognosticate, because other things that may be not much specific. In limitations of immunofluorescence or this this is an electrophoresis studies are that yes, they can be found in other causes, because free light chain may be high in like diseases like HIV, but in those cases ratio is important, because alteration of the ratio is very important. Above a certain level, it suggests this is a light chain disease. And he asked about light chain, gives a clue. This is a whether what kind of this lambda type and kappa type in a biopsy, because it should be routinely done in non-kidney biopsy patients, because without any clue you can get an either restriction of kappa and lambda. He has asked you what is a restriction about kappa and lambda. He has rightly told that. And he has asked you, do you know regarding any extracorporeal treatment with advances? Yes, this is a PMMA hemodialysis. This is a kind of heme absorption that absorbs this light chain and gives a better outcome in some cases. And some discussion was also on the hematopoietic stem cell transplantation. He concluded the session with the idea to assess the patient in a totality, and to the functional ability, give a proper diagnosis, give a crisp history, and towards the diagnosis. And it should be very calm in the examination, and it should be not very tensed. This is the wisdom we got from a great teacher, and thank you, sir, for this, for being with us.
Sorry. Kind of happened.
Sir, because we cannot hear it just properly. Hello, sir. Hello. Okay. Am I audible? Hello.
Yes, sir, you are audible, sir.
Okay. As we are running short of time, probably you can.
Thank you for that. And for the technical glitches.
Sir. Mr. Amol.
Yes, sir.
Probably some connection problem.
Yeah, I'm trying, sir, from my end. Is there anything technical glitch? Hopefully, everything is connected, sir, perfectly, Wi-Fi and all these things. I guess, sir, have the low bandwidth, so maybe. Hello, Gopal, sir.
Okay, we can go to the. Sir, if you can hear us, you can stay with the. We'll do one or two OSKI questions, very short, very fast round. And Dr. Aniruddha will be presenting two OSKI questions. Pallavi, read the question and try to answer the question.
Sir.
You can exit from your screen sharing or you've already exited.
Is the screen visible?
Yes, yes.
Yes, sir.
Okay. So we'll directly go to the first question.
18-year-old male complains of intermittent flank pain for last 7 to 8 months. No history of hematuria. CBC hemoglobin 12.5, PC 4500. It's normal. Creatinine 0.98. Urinary showing no albumin, no pus cells, and 2 to 3 RBCs.
Okay. So
So,
what do
but
you see?
investigation and what do you see here?
Sir, in the ultrasound, I can get, sir, there is hydronephrosis in the right kidney.
Okay. So how do you know this is hydronephrosis? Is it not a cyst?
Sir, there is a pelvic ileal system dilatation can be appreciated in this ultrasonography.
They are communicating. If they're
No.
non-communicating,
Non-communicating hydronephrosis is
then they
there.
are cyst actually. Here they are communicating. You can see the communication. Okay. So what do you see and what will be your next step and what are the differential? This is already how to differentiate with the cyst. So what will be your next step?
Sir, next we can do CT urography or MR urography to delineate the parenchymal lesions. Or third, we can also go for DTPA to assess the renal function in cases of unilateral hydronephrosis.
Yes. What do you see here? What is the investigation?
So this is the CT showing the hydronephrosis of the right kidney.
So it is a hydronephrosis.
It's a non-communicating hydronephrosis, sir.
So,
Non-communicating hydronephrosis.
what is the common differential diagnosis?
Sir, common differential diagnosis can be PUG obstruction, it can be congenital, or it can be, sir, acquired. Acquired can be due to the, sir, it can be due to any urethral stricture can be there, stones, tumors, retroperitoneal fibrosis can be there, and in congenital uh, there can be smooth muscle cell abnormality can be there, and the second there can be crossing of the vessels can cause
Back one slide. So can you see the ureters dilated?
ureters. Yes, sir.
Is the pelvis dilated basically?
Pelvis, it is the pelvis.
This is the pelvis.
So when you get this kind of picture, it should please a close diagnosis is the next CT scan. What is the this is what is this?
It is the, sir, contrast CT urography.
Yes. We
What
show
do you
what?
see?
The dilated pelvis or it is something else?
So dilated pelvis.
What is an extrarenal pelvis? This is the problem. You can see the pelvis is slightly extrarenal and it is appearing to be a dilated one. It is not an obstruction or dilatation. It is bilateral and is a bilateral extrarenal pelvis. It's a common differential diagnosis and there is no obstruction. Okay. So what will you do in this patient? Right flank pain with right-sided hydronephrosis with suspected PUG obstruction.
Sir, to rule out between obstruction and dilatation, so we need to do DTPA scan.
Read it.
So in DTPA, sir, we can get scarring of the sir left kidney.
You read the card.
Did you play? Max. So there is no, so there is obstruction in the right side because there the curve is plateau and it's not coming down, while the left side is apparently normal.
Normal response. So there is a initial peaking and then gradually it is cleared out. In the right side, in the green one, you can see there is no clearance. Okay, even after 1 hour of time, there is no clearance. Okay, so there may be an obstruction. So this is called PUJ with obstructive pattern. Okay. So what will you do next?
Next, sir, depending upon the DTPA, we can decide for whether the patient need to be conservative medical management or surgical management. Sir, if the differential renal function is less than 35%, then the surgical intervention is required in the form of open pyeloplasty, laparoscopic pyeloplasty, and in the, sir, if the differential function is if the renal function is less than 10% with symptoms, then patient can be offered nephrectomy.
Next slide. Okay, question.
25-year-old primary gravida lady.
Just to conclude, in the other case, if the simple two lines are, if there is an obstructed pattern, you need to intervene because it can be dynamic obstruction, it can be static one.
Yes.
So if there is an obstruction and that doesn't improve with the diuretic, and it shows that they write the reports are obstructed pattern, you need to intervene. If the kidney function is slightly compromised or relatively preserved in these cases, you can do a small surgery like a pyeloplasty. And if this is a kidney severely thinned out cortex and non-functioning, in those cases you can perform a two-way, either pyeloplasty followed by nephrectomy or maybe nephrectomy alone. So this is a common problem you get in the day-to-day clinical practice. Okay, this is not very important for the exam purpose, but you get this kind of patient and the anxious parents may come to you with that for the advice. Okay, and in the next is a similar one you did.
25-year-old primary gravida during ANC checkup up to 24 weeks found to have an AP diameter of 10 mm in right kidney, and follow-up USG on ANC on 38 weeks. APD was increased to 15 millimeters and AFI was 15. So there is the USG showing hydronephrosis of the right kidney. Postpartum, sir, generally hydronephrosis is a physiological phenomena in pregnancy, so we will definitely monitor till 6 weeks of the postpartum period, and we will follow up with the sequential ultrasound and renal function test.
Sometimes we get this kind of report, fortunately, because sometimes it is missed. It's very important because you need to follow it up after the delivery.
Yes, sir.
Very important. Okay, even though there is a minor obstruction, mild dilatations, still you have to follow it up in the postpartum period. So how do you follow them?
Renal function test and some ultrasound for the AP diameter we will look for.
Next.
What do you see? Sir, this is an X-ray showing large capacity bladder.
Pardon me?
Sir, this is an X-ray showing
Investigation. What is this investigation?
It's sir.
You can get it, take the urethra, you can get in the bladder, but in absence of urethra, what is the investigation?
It's an RG. RG.
RGU. You can
No,
get,
sir.
you are getting the bladder.
No, sir. It is cystourethrogram.
It's
MCU film of the
MCU
X-ray.
picture, yes.
MCU.
And also, what do you see here?
There is a urethral stricture.
It's a newborn one, and
MCU में how do you get strictures? Stricture नहीं दिखते.
which kind of obstruction you get in MCU? You can diagnose.
Sir, bladder outlet obstruction are generally
Which
diagnosed.
one? It is incidentally, suppose in this patient you are doing an MCU and you get something abnormal, you tell that there is this abnormality of bladder outlet obstruction is there. So once you get obstruction in one part, you may get an obstruction in other parts also.
Okay.
Okay. So how do you diagnose a posterior urethral valve?
Which, sir, avoiding cystourethrogram is one thing, and sir, for any obstructive pathology to rule out, we need to further follow up with cysto.
Yes, Aniruddha will tell the rest.
Basically, whenever we are having an antenatal hydronephrosis and which is increasing significantly, so like in this case, we had a diameter of more than 15, around 15 in the 38 weeks. So postpartum, usually what is advised to do an early ultrasound and to find out what is the status. So as we see postnatally, there was also a presence of hydronephrosis. You do a VCUG or a MCU to rule out whether there is any reflux. And if there are no refluxes, then you are supposed to proceed to do a diuretic renogram. So in this case, this was the diuretic renogram of this patient. So usually the diuretic renogram is deferred till the time the nephrons mature. So around second, third month of life. So at that time, a diuretic renogram is done. And in this case, this was the finding. So what do you see here?
There is a. This is a normal. Right sided is a slightly delayed. Excretion is there, but in the left side it is normal.
Okay, so yeah, essentially left is normal. In right side, what we see is there is a response to the diuretics. So after the diuretic, there is a rapid clearing of the traces. So in this case, how would you proceed to manage this? Would you intervene surgically?
We will look for the differential renal function. If it is less than 35, then we need to definitely intervene.
So here the split function is, the differential function is not less than that. And you see the there is a positive response to the diuretics, which is responsive. So usually here what is advised to go for observation. So frequent monitoring by ultrasound and checking the renal functions, and the diuretic renogram is supposed to be repeated. So in this case, the USG at around 6 months showed there was resolution of the hydronephrosis. 6 months. So to elaborate, this is the definition of the fetal hydronephrosis, which is defined by the calicial dilation of grade 2, which is using the Society of Fetal Ultrasound Scoring System, which I have shown in this illustration. And it's defined by a renal pelvis diameter more than 4 mm at less than 33 weeks of gestation, or 7 mm at more than 33 weeks of gestation. And again, it becomes significant if there is grade 3 or grade 4 hydronephrosis, that is the renal pelvis diameter more than 10 mm. And to elaborate on the renograms, the diuretic renograms, the first one, these are known as the O'Reilly's curve. And the first one is again essentially the normal renogram, non-obstructed one, which is known as type 1. This is the type 2, which shows presence of obstruction, and obstruction which is fixed, and that is at 20 minutes, at this 15 minutes, there is no response to the diuretic. And coming to the third one, this is the known as the type 3A. So there is response to, there is rapid clearing after the diuretic, so which signifies a functional obstruction or essentially an obstruction which is due to stasis. So here all three curves are summarized together. And another type which is known as the type 4 renogram can be seen when there is a biphasic flow or there is a response to initial rapid response followed by reversal or at higher flow in case of type 4 renogram, which can be seen in case of VUR. So again, usually the radiopharmaceutical tracer agent of choice is the technetium 99 labeled MAC3 over DTPA. And this is the algorithm to follow up post antenatally detected hydronephrosis, depending on the grade of the hydronephrosis and depending on the MCU findings. They can be treated by following up by diuretic renography, and depending on the diuretic renogram, whether it has a normal drainage or a poor drainage, as you were correctly saying, depending on the split function. If there is more than 45% differential function, then you simply follow it up with 3 monthly ultrasounds within 35 to 45, 3 monthly ultrasounds and MAC3 at least twice a year. And if the differential function is less than 35, definitively going for directly for intervention as pyeloplasty. And if in these serial follow-ups, there is at any point of time, there is evidence of decreased function, you directly proceed for a surgical intervention as pyeloplasty. Now, in the initial first case, whenever we are considering an adult or any patient having a ureteropelvic junction obstruction, the indications for surgery is to whenever you have a presence of symptoms like which are associated with obstruction, like pain or hematuria, or if there is associated calculi, as well as if there is impairment of the overall renal function or progressive impairment of ipsilateral function. Here serial imaging, if they show there is more than 10% decline in the renal function, or if there is if there is development of recurrent infection, or rarely if it causes hypertension, then surgical interventions are advised. And the surgical interventions can be open or laparoscopic or robotic. The open interventions can be dismembered pyeloplasty like the Anderson-Haynes pyeloplasty, or it can be non-dismembered or flap-based pyeloplasties. And another endovascular or the endopylotomies are also available. However, they have significantly increased, especially the antegrade endopylotomy have increased risk of bleeding. So coming to the last question.
A 70-year-old male, diabetic for 30 years, complains of dribbling while micturition, straining and urge incontinence. CBC almost normal, creatinine 1.75, HbA1c 7.9, PSA 2.5, ACR 250, urinary showing albuminuria of 2+, pus cells of 8 to 10 and 5 to 7 RBCs.
Okay. And at 4 weeks.
So at 4 weeks follow-up, CBC hemoglobin 12.7, PC 9000, urinary showing albumin 2+ with pus cells of 7 to 8, creatinine has gone up to 2.1, urine ACR has also increased to 356, and culture showing no growth. How will you investigate?
Appears to be a simple diabetic nephropathy. Diabetes patient albuminuria increases here, rising in creatinine, but something that rise is slightly rapid. So do you want to investigate this?
Sir, first we will like, apart renal function, we will like to imaging for ultra USG KUB with PVR assessment, and prostate assessment should be done as the patient is older, so we need to rule out BPH and other factors.
What do you see in the image?
So it's a ultrasound image showing dilated pelvic initial system of the right kidney, left kidney. Cysts are there in right kidney, left kidney.
Yes. It's a bilateral dilated system. And what about the lower panel?
And in the lower, this thing, sir, AP diameter is around,
This is the post-void image of the patient.
yes, sir.
So it appears to be high or normal.
Sir, this appears to be high.
So there is a increased post-void urine. At the same time, there is a bilateral dilated pelvic alysial system. And ureter is not mentioned, but probably it is also dilated. So in an elderly diabetic patient, if you get this, so what will you do next?
Sir, we will like to rule out diabetic cystopathy. For this, we can do, sir, urodynamic study to rule out neurogenic bladder, or before that we can do such uroflowmetry also.
So this is the uroflowmetry.
Yes, sir. Uroflowmetry suggests it is a interrupted flow it's seen, and
There
it's
is an
a
obstructed flow. Is the test adequate? Volume is 300 ml.
yes, sir. Volume 300 is adequate. Flow it's a borderline 10 ml per second.
Max is 10 only.
10 only. And it is an interrupted flow, so probably some neurogenic bladder is the cause.
So what will you do?
Sir, for neurogenic bladder,
It can be obstruction also, no? Prostate, and there's repeatedly straining and getting some flow.
yes, sir.
So you need to know obstruction due to prostate or bladder outlet, or is a neurogenic bladder itself. So what test will you do next?
Sir, to rule out obstruction and this thing, we can do, sir, micturating cystourethrogram to rule out obstruction.
So increase residual volume. Okay.
Yes, sir.
Will you do an urodynamic study?
Sir, I'd like to do urodynamic study.
Yes. So before urodynamic study, they ask, and you also need some investigation that should be negative before putting the patient on
The urine culture has to be negative before going to urodynamic study.
Yes. So what do you see here? You read the pressure and give your opinion.
Sir, there is detrusor.
If you're not very conversant with this thing, then only with ID.
Flow, this is a straining kind of flow, and this is the this lower curve is suggestive of the lower curve is suggestive of obstructive pattern, and there is a detrusor overactivity.
It's an underactive.
Underactivity of the detrusor.
So you see the entire curve, the entire curve is flat. So even if when you are voiding, your volume is increasing, your flow has not increased, your vesicle pressure is increasing, but the detrusor is not contracting. So with time, your vesicle has filled up, your vesicle is filling up, you're trying to contract, but even if when the vesicles are filling up, you don't have detrusor activity. So it's a hypo.
Increase abdominal pressure, that is getting the benefit of some putting some urine.
Yes, the intra-abdominal pressures are getting high. So in a sense, this is a detrusor underactivity or a hypo.
So it suggests a neurogenic bladder. So diabetic patient is an increased residual volume. In spite of there is a proteinuria, there is some obstruction. So this is a part of neurogenic bladder, basically. The hypocontractile detrusor. So for this patient, what treatment we should provide?
Sir, urogenic bladder with underactive detrusor, sir, if the urinary, if there is a PVR is high, then intermittent CIC can be prescribed. Along with, sir, we can give anticholinergic agent can be there, can be prescribed. And sir, plus minus botulinum toxin has also been tried. And if all this fail, if the medical management fails and patient is still symptomatic of recurrent UTI and recurrent UTI, then sir, surgical procedures such as urinary diversion are can be taken, can be advised.
What is the problem with the medical therapy in such patients? In elderly patient, if you put Bethanicol in such patients, what may happen? Risk related to Bethanicol.
This was the ECG of the patient.
QT, so,
See, some sort of bradyarrhythmia is there.
yes, sir.
Okay. So this is the problem is giving that such kind of drugs in elderly patients. So safe intermittent clean catch catheterization, that is one important, but it is not very easy for an elderly person who cannot see properly and doing it aseptically. So next on will tell what should be the treatment for such patients.
So as you correctly said, this was a diabetic cystopathy. Mainly the pathways which lead to underactive or detrusor underactivity would be involving the brains or the afferent pathways from the sacrococcygeal region, or the efferent pathways or the afferent pathways, or the in the muscles which can be involved, the afferent pathways and the muscles which can be involved in diabetes mellitus. And so again, the diagnostic methods, what we used was mainly the urodynamic measurements, which are simple and mainly clinically used. The other indices may be a little bit difficult to calculate. So as you were saying, in the therapy of these patients, the drugs which are used mainly are the anticholinergics, the muscarinic agonists. But in these cases, what can happen? There can be cardiodepressants. So the patient who already has an undergoing bradyarrhythmia or a established heart block may develop further bradyarrhythmia. So in these patients, apart from these drugs, self-catheterization or double voiding can be done, or eventually, if to improve the drainage, urinary diversion can be done. The patient can be advised to undergo any kind of bladder outlet surgery or use of other muscle relaxants or alpha blockers to counter whatever amount of, because usually whenever in diabetic patients at this age you have a detrusor underactivity, you may have a concurrent bladder outlet obstruction because of the prostate, and also other neuromodulation and anterior sacral root stimulations can be done, but they are again not very widely used. And the other experimental therapies which you described, the intrasphincteric botulinum, because of its invasiveness as well as the periodic repeated requirement of use, it's not very common to be done. And intravesical electrotherapy, detrusor myoplasty and reduction cystoplasty are again experimental therapies which are not again very widely used. So with this, in this, our patient probably doing the CIC would be safest in his age group, considering his cardiac condition and his.
Okay, thank you. We have kept these OSKIs because these are the common things that we find in our OPDs or in the clinics. Anxious parents coming and asking for the opinion regarding this incidental EVG finding, or your friend can tell you that some of his relatives have developed a hydronephrosis just in the pre or the immediate postpartum period. And sometimes an elderly patient diabetic goes very rapidly down in terms of kidney function, and you need to exclude the obstruction. At the same time, you will give a decision to treat them. So we can conclude the session now because a very long class. So thank you again, Dr. Gopalakrishnan sir, for being with us and giving nice inputs regarding this. We have learned a lot from you, the different parts, not only for the disease, also to look after the disease in totality. Thank you, Aniruddha. Thank you, Pallavi. Mr. Amal.
Thank you so much. Thanks for the opportunity. Thank you.
Sir. Okay. Thank you, sir.
Thank you, sir. Thank you, Patidas sir, and thank you, Pallavi madam, for fantastic presentations. And thank you, Aniruddha sir, for attending that. Thank you so much.
Good night.
Good night.